Oftentimes we find in a standard lumpectomy where there might be some postoperative clips, it's very hard to determine where that lumpectomy cavity is really located. So in many ways it's a little bit of a guess where to put that radiation dose for the last week or so of their radiation treatment. One of our local treating breast surgeons, Dr. Carrie Coughley, came to our practice with the idea of using the BioZorb. I have to admit we were a little bit skeptical. We thought as radiation oncologists we're pretty good at contouring lumpectomy cavity volumes, and we didn't need additional help. My dosimetrists and therapists were also skeptical. Dr. Kaufman and I have been working together for a long time, almost 10 years now. We had been doing standard post-operative radiation treatment for breast cancer for essentially all of that time. In our practice that was typically either conventionally fractionated whole breast radiation with a boost, usually taking 6 or 7 weeks to complete, or accelerated whole breast radiotherapy with or without a boost. But the study was really done to help us determine how best to use the BioZorb and help us figure out sort of could we reduce a margin or figure out how it was going to be useful in our clinical practice. We presented a 10-patient initial pilot study at the American Society for Therapeutic Radiation Oncology in 2016. That study was an experience of our first 10 patients who had a BioZorb implanted into their breast at the time of lumpectomy. Those patients were all treated with a combination of whole breast with boost or partial breast radiation therapy without really incorporating knowledge of the BioZorb or what we were going to be using it for because we were really in the early days of our experience with the BioZorb. Dr. Carrie Kaufman participated in the trial with me. He also provided a lumpectomy cavity recontour volume. And then we used a Boolean operator to combine those cavities together into one volume, which we called our collaborative target volume. Then all 10 scans were again reviewed by the radiation oncologist, myself, and Dr. Kaufman to make sure that we agreed that that cavity volume was appropriate for treatment. We then compared our collaborative volume for each of those 10 patients to the original target volume that we had contoured in our clinical practice and used for treatment. So basic statistical tests were done. We saw about a 60% reduction in our target volume using BioZorb to inform the contour. We've also found the BioZorb to be very useful in streamlining our clinical practice at the time of treatment. We use the BioZorb and a cone beam CT. We can basically line up our cone beam CT to our treatment planning CT scan as a fused image set. We'll adjust to make sure each of our 6 BioZorb clips are exactly where they're supposed to be and were in the treatment planning scan. We're usually making adjustments in the range of 1 to 2 millimeters, which is quite small, and then we treat the patient. So versus 10 to 15 minutes for each treatment before, we now spend 1 to 2 minutes looking at those scans. And in many cases, we use the cone beam enough in all of our other applications. Our therapists are able to proceed with treatment as long as they're not exceeding a few millimeters of shift and treat the patient without the radiation oncologist needing to look at the scan before each treatment. BioZorb for the radiation oncologist really helps with visualization, which is really what our entire practice has become all about. The therapists, especially who are treating patients on a daily basis, really like to see that BioZorb. And our dosimetrists at the time of planning like to see it because they're very confident that where we're putting our radiation dose is the right place in the patient.